Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on pleural effusion under the section of respiratory medicine. So let's cover the types of pleural effusion first. Broadly speaking, they're divided into two types. First one is transudate, which is normally you get a clear or straw-colored fluid. And the second one is exudate, which is when you will get a turbid or bloody fluid. So the biggest thing that you might ask in terms of how to differentiate between a transudative pleural effusion versus an exudative cause, which we will be covering shortly, is really a few factors. So in the sample that you're taking from an aspiration of the pleural fluid, you will be testing it for pH, protein, LDH, cell count, and fluid to serum LDH ratio. In a transudative cause, you will have a pH of greater than 7.3, a fluid protein of less than 30, a fluid LDH of less than 200, a fluid serum LDH ratio of less than 0.6, and a cell count of normally less than 1,000 of white cells. And the exudative cause, as you have guessed it, is going to be the opposite of that. So your pH is going to be less than 7.3, making it quite acidotic. Your protein is more than 30. Your fluid LDH is more than 200. Your fluid serum LDH ratio is greater than 0.6. And your cell count is more than 1,000 of white cells. I'm pretty sure that most of you who are taking this exam has heard of a light criteria. And Light's criteria is there to help you to differentiate between a pleural effusion, whether that's an exudate or a transudate. According to Light's criteria, a pleural effusion is an exudate if the plurals to the serum protein is more than 0.5, the plural to the serum LDH is more than 0.6, and the pleural fluid LDH is greater than 2/3 of the upper limit of normal compared with the serum. It's also important to note that if the Light's criteria indicate the presence of an exudative effusion, however, the patient is thought to have a transudative effusion based on their previous medical history and examination and history findings, then it would be really important to check the serum pleural fluid ratio gradient to help you differentiate it further. Now, this is a list of the causes of both transudative and exudative pleural effusion. This is really quite a common exam question, especially in PACES. Having a case of pleural effusion is really common. And as part of your viva, you can expect the examiner to ask you about the causes of these two and how will you be differentiating between the two, which is what we've already covered. So the transudative causes include all of your failures. So that's your heart failure, liver failure, renal failure, nephrotic syndrome, hypothyroidism, and sarcoidosis. The exudative causes include malignancy, infection, connective tissue disorders, and trauma, for instance, in the case of hemothorax. There are some other rarer causes, including Meigs syndrome, pancreatitis, familial Mediterranean fever, Yellow-Nair syndrome, and Dressler syndrome. The signs and symptoms of pleural effusions are very much something that is expected for you guys to be familiar with. These include reduced chest expansion on the affected side, reduced breath sounds on the affected side. There will be dullness on percussion and decreased vocal resonance. And then you will need to be examining the appropriate part of the body when you're suspecting a pleural effusion in the case of PACES. So for instance, if you think the effusion is secondary to connective tissue disease, then making a show of thinking about that specific connective tissue disease, whether that's rheumatoid or whether that's any other connective tissue disease that is linked to pleural effusion, would be important in your PACES examination. As part of the investigation that you would want to do for pleural effusion, as discussed earlier, having a thorough history and examination is key. Then you would move on in a systematic order, so asking the patient to have their observation checked at the bedside to find out whether they would need any supplemental oxygen or not, before moving on to blood tests to include and check for inflammatory markers, blood cultures, and protein in the blood, as well as the LDH levels. You would then ask for a chest x-ray, and that's pretty much when you have your effusion confirmed frequently. However, the gold standard diagnosis would be to have an ultrasound scan of the site of the effusion to help with the pleural aspiration, which you will need to send for MCS, protein, LDH, and cell count and glucose to help you with differentiating between your exudative and transudative causes. And then further imaging will need to be carried out as per your suspicion of what is the cause of the pleural effusion. For instance, if you're thinking about Dressler syndrome, then having an echocardiogram would be appropriate. So this is just a radiographic image of a right-sided pleural effusion. As you can see, this is quite different than somebody who has got, for instance, a consolidative change, because you can clearly see the costophrenic angle on the right side is completely blurred and you're unable to appreciate the right heart border also. So let's do some questions. A 60-year-old man presented to the acute medical take with a history of unintentional weight loss of 2 stone and hemoptysis. On examination, the IMT1 doctor notes cervical lymphadenopathy and right-sided reduced chest expansion and breast sounds, with associated dullness to percussion. The respiratory registrar on call performs an ultrasound-guided pleural aspiration. Given the likely diagnosis, which of the following statement is incorrect? A CT tap is indicated. B, cigarette smoking is the biggest risk factor for this condition. C, increased vocal phreatus will be expected on examination. D, the pleural effusion will be consistent with an exudate. E, a pH of less than 7.2 could indicate a complicated empyema. So to answer this question, let's just revisit the vignette again. So you have a middle-aged gentleman who's presenting with unintentional weight loss and hemoptysis. And hopefully that is enough for most of you to appreciate that the big thing that you need to be worried about in this case is either A, cancer or infection. It then goes on to tell you that the IMT1 doctor has picked up cervical lymphadenopathy and signs and symptoms that is consistent with the pleural effusion. And in fact, it tells you that this is a pleural effusion because later on it tells you that the on-call respiratory registrar has performed an aspiration on the case. So this is hopefully, given the fact that there also isn't a mention of any hemodynamic instability, suspecting of sepsis or raised infection markers, or for instance, pyrexia, hopefully this is all leading you towards cancer. And looking at your choices, option A is saying that the CT tap is indicated. That sounds reasonable because if you're suspecting a cancer, you would want to be thinking about what's the extent of this disease and how far has it spread, because obviously that is going to change the management that you would be offering to the patient. Option B is saying that cigarette smoking is the biggest risk factor for this condition, which is also true because smoking remains the biggest risk factor to develop lung cancer. Option D, it tells you that the pleural effusion will be consistent with an exudate. Well, that's correct, whether that's an infection or cancer. Option E is saying that a pH of less than 7.2 can indicate a complicated empyema, and that is also correct. If you have a pH of less than 7.2, that suggests a very acidic effusion, and that the first concern would be that this could be an empyema, which would be an indication for drainage. So the only thing that is going to be left that will be the incorrect option here, which would be the correct answer, is option C, which is saying that you would expect increased vocal phreatus on examination. That is incorrect because your vocal phreatus will be reduced in the case of a pleural effusion. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.